Perfect. So with that, perfect opportunity again to welcome you all here to the Elder Services Provider Council Compass for Caregivers webinar. Our topic today is hospice, and I am very excited to welcome my friend and colleague, Patricia Ortiz-San Miguel. Patricia has been here with Frederick Health Hospice since 2016, worked for another hospice before that for a few years, and had her very own personal journey without hospice that led her to find a role in the organization. Again, we're going to ask you to use the Q&A and the chat buttons to speak with us. Patricia, oh, please, I apologize. Before Patricia joins us, I forgot to say thank you to our sponsor, Amber Hill Physical Therapy. I hope that you had the opportunity to view their video, their brief video. They have 6 locations here in Frederick County, offer great rehab service. So encourage you, please, we'll put their contact information up at the end of the presentation. We very much appreciate their sponsorship, and we hope that you will reach out to them if you have any questions or physical occupational therapy needs. With that, Patricia, I will ask you to turn your microphone and your camera on. I'm going to give you the spotlight, my friend.
Hello. Thank you so much.
All right. So welcome. Very glad to have you. I'm going to turn it over to you.
Thank you so much. And thank you for everybody that's popping in. It's clearly a topic that I'm very passionate about. I didn't arrive at hospice as a first career. It's been through personal experience through the healthcare system that I've arrived here. So it's still a huge passion to share with everybody what hospice really is and isn't. And I welcome all of the questions that you have, even from the very beginning. If you have questions right away that you can't really focus or take in anything of the rest of the presentation without asking, please go ahead. This is personal for everybody, and I welcome the feedback and the interaction throughout. So with that, we can turn to the first, actually second slide will be. And then the next slide, please. So I am with Frederick Health Hospice, and we serve people in Frederick as well as Montgomery County. And the best way to describe hospice is really a group of services that comes to you wherever you call home. So it is not a place, it is not a physical spot where you go to receive care. We actually come to you and follow you throughout the different places that you may be calling home at different times. It could be your personal home, it could be your loved one's home that may be taking care of you, a friend's basement, it could be any type of facility, whether it's independent living, assisted living, or nursing home. It could even be the shelter. So we will go to wherever people are calling home. Our focus is really on the whole person. So we're looking at physical symptoms. We are looking at emotional and psychological symptoms. And we are looking at really at financial and social symptoms that people experience depending on where they're living. Sometimes we have loved ones that have been the breadwinners, and one of their big things is, how am I going to make ends meet for my family as I go through this illness? So we really take a look at everything that's going on in our patients' lives and in the lives of the people that patient will call their loved ones and their closer circle. Next slide, please. So part of the philosophy of hospice is being able to have the patient and their families be more in control of their medical care and their care overall, so that they're able to match their values and what they most care about, what's most important to them, to the care that they're receiving. So really that care can be supportive of moving ahead with your life's goals as you go through these serious illnesses. One of the big myths and misconceptions out there about hospice is that it's for when you are 3 steps away from death. And that really couldn't be farther from the truth. And I'll expand on that a little bit later on throughout the presentation. But basically, we are looking to serve patients who have a life-limiting illness that really is causing quite a lot of symptoms and doesn't let them live fully, however long they have in life. Next slide, please. So, and I'll talk a little bit more about what life limiting means, because that's kind of a catch-all term, and I want to give better examples about what that really means. But basically, you are looking for somebody who has some kind of illness that just by having it, it shortens the time that they have to live in comparison to their peers that don't have that illness. Okay, so that is what a life limiting illness is. You may not know the outcome of that particular illness just yet. Like, for example, cancer. You may be diagnosed with cancer and you may have different prognosis throughout the process of the disease. And you will be eligible for different services throughout that process. Next slide, please. So the big thing that's on everybody's mind, especially now after the pandemic, is who pays for this care. And hospice is fully covered 100%. There's no deductible or anything like that for everybody, whether they have private insurance, Medicare, Medicaid, they don't have insurance at all, or they don't have documentation status to be in the US. It really doesn't matter. We serve everybody in the same way. Our nurses, most of the time, don't know the financial status of the people that they're serving, so it doesn't impact our care at all. So never let the financials be a barrier to care for hospice. Next slide, please. So I touched on this a little bit, where you can receive care at home or nursing homes or shelters. And we also, for those who cannot be served in any of the before mentioned places, we also have the Klein House, which is meant for people who are very close to death, maybe about a month or so left of life, just about, although nobody has a crystal ball. And it's a home where you receive 24-hour-a-day care, and you also overlay all of the hospice services onto it. And it's a small house. It has 6 bedrooms where we can give care. Many times the most used, the way that this is most used in is for those who have been receiving hospice care at home, for example, and are nearing the end of their life and do not want to die at home because they have multi-generational situation in the household, and there's too many things going on, or they may not be able to have anybody that cares for them in the home, and they're unable to do that for themselves. They will be transferred into the Klein House. This is the only piece that has some cost associated to it. It's on a sliding scale for Frederick County residents, and what we're charging is the room and board, not the hospice services. The hospice services, the medicines, the equipment, all of that is already covered under hospice. So this is truly just the room and board aspect of it. Next slide, please. So what is this group of services? How I like to describe it. It's a multidisciplinary team that you will have available to you. So we have under your team, you have the people associated with your care. We cover the equipment associated with your care, and we cover the medicines associated with your care. Under the people associated with your care, you have our medical director, you have our nurse case manager. They act as the coordinator in chief for you throughout the whole process of hospice. We have our home health aides that do all of the personal care aspect of our services to the patient. We have our chaplains, our social workers, we have volunteers, we have pet services, we have music therapy. So it's a pretty robust set of groups that can be involved in your care. Now, the way it's put forward, really, I said at the very beginning that we want you to be the driver of your care. So if you only want the nurse to come out and take care of you, but you really don't want the home health aid services, or you don't want the chaplain services, you don't have to have them. You can incorporate them at any time. We can scale up how many people are involved in the care and scale it down as you see fit and as that matches with what you are looking for. So as long as our medical director and our nurse can have access to you, to the patient, then everything else can be overlaid or taken off as the person feels that they need, and as we as a clinical team assess what the needs can be. In terms of the medical equipment, we cover that also. So if the patient were to need oxygen or a hospital bed or a bedside commode or a different wheelchair or mattress, all of those things we cover, and they get delivered to the home. So there's no running around to the pharmacies and trying to call. We coordinate all of that care and we just deliver everything to your house. As the needs change, we can add more equipment or take away equipment so that you're not having a bunch of pieces of stuff around your house if you don't need them. And we will coordinate all of that for you. And then the last section that we take care of is the medication. So we will take over all of the medication for the patient. We make sure that we're having an optimized regimen of medication for that patient, and we deliver all of the medications to the home. So you don't have to worry again about leaving your loved one to go to the pharmacy to then bring back the medication. It's everything's delivered to your house. The only medication, the only exceptions to us covering a medication is when that particular medication preceded the hospice environment, and it's for something that has nothing to do with the reason why the patient is under hospice care. And I'll give you an example. For example, we have a patient under our care for dementia or for, cancer or COPD, but they in their 20s had an eye surgery, and they take drops for whatever was the reason for that eye surgery. Since then, those drops have nothing to do with the reason the patient has this particular life-limiting illness. It has nothing to do with what's causing the symptoms of the patient to not feel well. So that medication stays covered in the way it's been covered for you before. That's kind of the only exception to what we wouldn't cover, but pretty much everything else, we will be the ones covering it. Next slide, please. So grief support. We in hospice, we really look at a continuum of care, both for the patient and their loved ones all throughout the illness, and then later on as well. So we will continue to serve our families for over 13 months after the patient has died. We also have counseling, one-on-one counseling, as well as group support that is free to the community. And when I say to the community, I do not mean just the people that have had a loved one in hospice, but really to the community at large. You may have lost somebody to traumatic death. You can avail yourself of the grief support that hospice offers. All you need to do is give a call and we'll set you up with our grief counselors. We run 2 camps a year for you, specifically for youth. One of them is coming up in April 2nd, and then we have another in June and in September. And we take kids from grades 1 to 8 in one of the camps, and the other camp is specifically to support our teens up to the age of 18. Next slide, please. So this is where the presentation gets a little bit broader, because we have a lot of services that we give and we're really wonderful, but people are very scared to look at hospice as an option for their loved one, because we carry the weight of really bad misconceptions and really bad reputation in terms of what the hospice word means, because everybody's associating it with a couple of days left of life. And like I said in the beginning, that's nothing further from the truth. When we look at hospice, we are looking at any kind of life-limiting illness, not just cancer. So we're looking at cancer and heart disease and lung disease and liver disease and kidney disease and Alzheimer's, dementia, or other neurological conditions like ALS, for example. So any part of the body, any organ, any disease associated with your body and your length of stay on this planet is a reason to think about hospice. Now, the big question is when. Okay, I have heart disease or lung disease or liver disease. When should I access hospice? And really the response to that is typically sooner rather than later. Specifically for cancer, the American Cancer Society came out with some best practices, and it is to get a consult when they're on the onset of diagnosis with at least a palliative care physician, so that you can start thinking about the whole patient in terms of symptom management. But when you have a loved one with a life-limiting illness, and that loved one is going to the hospital maybe twice a year to manage their symptoms, let's say a heart patient is having to seek hospital treatment twice a year to get diuresis because they have too much fluid in their body and they need to get rid of that fluid. They are starting to change their activities to match their symptoms, right? When we talk to some of our patients, they say, oh, we're doing just fine. But you dig a little deeper and you realize they're doing just fine because they have stopped doing the activities that they love so that they don't get symptoms. And that's how you miss a lot of people that could benefit from our services a lot sooner, because the right question isn't being asked, which is, what are you not doing that you wanted to do so that you don't get short of breath, so that you don't get edema in the legs, that you don't get swollen legs or swollen limbs, so that you don't get really tired, really fatigued, and are out of commission for 2 days. Those are the right questions, because we try to self-preserve, right? So we try to not do those things that cause us difficulty or pain. So we stop walking our grandkids to the bus stop because we don't want to be short of breath. We stop talking on the phone to people that we love because just the exertion of having a conversation, sustained conversation, really gets us short of breath, right? We stopped gardening because it's really hard with all of your swollen limbs from all of the fluid retention to be able to bend down and work with your potted plants. So those are the things that we are looking for that tell us how a patient is doing, and if they would benefit more from hospice services than from just managing their illness through going to the doctor and then going to the ER when symptoms get really bad, right? So when you have a life-limiting illness, which I described before, it means that your length of stay is shorter than another person that's your same age that does not have that illness, right? You're looking at a shorter lifespan than your peers that don't have that illness. And when that illness is making you stop doing the things that you want to do, you are now conforming your life to fit your symptoms and to avoid those symptoms, or you're using the hospital a couple of times a year to just manage your disease, not to cure it, not to give you a new heart or a new set of lungs, but to just manage the symptoms of the disease that you have, that is the time to have a conversation with hospice, right? And it's just a conversation. You're not signing away your life. You're not signing away your rights to good care. All you're doing is having a conversation to see if hospice can offer you the support that you need to manage all your symptoms in the best way possible so that you can resume the most of what you can do in your life for however long you have. Now, typically, we're talking about patients that will probably not be here in 2 to 3 years, right? Typically, our patients have a longer lifespan, a shorter lifespan than that. Typically, we have patients that can be around for, 8 months, 10 months, a year and a half. Sometimes we have patients that are around for 3 or 4 more years, and they come in and out of hospice as their symptoms manifest and as they look, they're feeling better or worse, and that happens too. But by and large, the large proportion of our patients will be looking at around a year of life. That being said, nobody has a crystal ball. And that being said, we in the outside of hospice medical community are terrible at figuring out how long somebody has. So really, that's why we try to look at, instead of prognosis, you have 3 months to live or 7 months to live, we are looking at what is going on in that patient's life. That disease is manifesting in a way that's interfering with their life and having to seek more medical care, to then decide, hey, is it worth a conversation? Should we meet? Should we talk about what we can offer? Now, if you sign up for hospice, this is an entitlement. This is a benefit hooked in, baked into Medicare. It was approved by Congress in 1982. It's been around for a while. So this is your right. It's your entitlement to be able to seek hospice services. And just as it is your right to sign up for hospice services, if down the line, as you're receiving care, you see that things are now not aligning with what your interests are, or maybe there's a different new experimental treatment that the patient wants to try, you can discharge from hospice at will. Just as you signed up, you call us and you say, you know what, we want to try this different curative treatment out there, and that's what we're going to do. And we say, let's do it, and I hope it works, and we'll be here if something doesn't go the way we all wish it does. So you can come in and you can come out of hospice depending on what's going on in your life. So really something that feels like a humongous decision in your life, like there's no turning back, like you can make the wrong choice if you don't really think about it really hard. It's actually not so, because you could always discharge from hospice if it's not matching what you want or what the patient wants in their life. Now, as I said, curative treatment and symptom management, I want to be very clear. One of the myths out there with hospice is that it's kind of like second-rate medicine. We don't do anything. We just hold a hand, and we do that. We hold hands because that's important, because we look at the entire patient and how they're doing, and we care about them and their family in their entirety. But we actually have first-rate medicine approach to all of the symptom management. We are experts in symptom management. That is what we do best. And that is why often when patients come to us, let's say with COPD, and they've been using their inhalers forever, right? When you have a chronic illness, you've been in a routine of doing things a certain way. But now you're reaching out to us because that certain way and that process of medicine is not working very well, because you're experiencing symptoms that are now interfering with your life. If everything was, hunky-dory, you wouldn't be seeking out other ways of care. So when the COPD patient comes in and we say, you know what, instead of this inhaler, we're going to change this to this, nebulizer machine. And people get really freaked out. Rayanne, I think we can go to the next slide now, please. Thank you. So people get really freaked out that they're not going to have their inhalers. And this is what I've heard, that hospice is not going to do anything with medicine. Well, guess what? The reason why you've been on that inhaler and we're changing it is because you're experiencing symptoms and the inhaler is not working. And the reason it's not working is that maybe your lungs are no longer strong enough to deliver the medicine in that inhaler through an inhalation all the way to the back, all the way to your lungs down there. So the medicine is the right medicine, the concentration is the right concentration, but the delivery system of that medicine is no longer something that your body can use to get that medicine to where it belongs. So we change the approach to then be able to get you the medicine that you need. It may even be the same medicine, except instead of an inhaler, you have a mask and it's doing the work for you, right? So that's where the myths of we throw away medication, it's second-rate medicine, we don't do so much comes from, because people, and especially people with chronic illness, hold on to their routines really tightly because it's what gives them comfort. Because it did for a while. It gave them comfort because they felt better. So it's natural that we have the instinct to do that. And it's really scary when you're picking something that looks different than what you've done. So that's where those myths come from. It's that sometimes we will tweak the medicine to better adjust for the symptom management of that particular patient. So our heart patients, we know they do better with their medicine. We know they do better with their Coumadin. And why would we want a patient that is not really well stable? That's what we do best. We manage patients so that they're stable and they can live the best life that they have for however long they have left. Now, do we then hasten death? I hear the other big one is, you kill with morphine. And I get what that comes from too. Morphine is an exquisite pain medication and an exquisite medication for helping with shortness of breath. It is not unlike ibuprofen, that it's, it has a decent price to it. We know a lot about it because we've used it for a really long time. So we know what to expect and we know what dosing does in the different categories. If you're a 60-year-old versus a 97-year-old, you have different biology, even if you're all considered seniors, right? So we know a lot about this medication and how to use it and how to dose appropriately for what we're looking for, which is why it's so broadly used both in hospital and outside of the hospital with hospice. Ibuprofen can help your headache, or you may be taking it to relax some of the muscle spasms that you were having so that you don't have so much pain on your shoulder because you gardened too hard, right? But nobody's saying, oh my God, I'm going to kill myself with ibuprofen, just by taking it in the appropriate dosing for the different things that you want to treat. That's why morphine is used very often, just as in the hospital. And with our hospice patients, we actually start at like half the dose, at micro doses, at about half the dose that we would give a pediatric patient. So even when we do start using morphine, which does not happen in every case, not every case warrants that type of medication, we will still use really small doses and really know how to use it. And even if it's a medication that would be well warranted to that particular situation, and the patient and their family are like super freaked out about using it, then you talk to your team. That's why we're a team, and that's why you're the driver of the care. You talk to your nurse and you say, hey, I'm super uncomfortable with this. Can you explain some more about it? Or, hey, I really, really don't care what you explain. I am not using this. Can we use something else? Because we're a team, because we're as concerned about your well-being as the caregiver as we are about the patient, right? There's a phrase out there that says, tell me how the caregiver is doing, and I will tell you how high need is a patient. And that's true. I have been a caregiver for various members of my family for a long time. And, when the needs get a lot higher, I start not doing as well. I don't look great. I have a lot of headaches, bags under my eyes, mismatched buttons, you name it. So we are as interested at keeping the caregivers well. And that means let's have conversations about what's going on and what we're doing so that you as the caregiver are comfortable and understand the care that your loved one is receiving. That is super important to us. We don't hasten this in any way, just as we don't miraculously extend life. However, there's a lot of studies that are coming out now that show that if you have two groups, they mirror themselves in profile, age, gender, disease process, all of it, and one accesses hospice and the other one doesn't, the hospice group either outlives or lives the same amount as the people that got the general thought of treatment. And if you think about it, right, it sounds magical, but if you think about it, if your loved one is avoiding hospitalizations just to manage symptoms, you know what that hospital stay is like. You're poked and prodded and woken up and, tested and retested and diagnosed with things that are not causing you issues. And then when you go back, the patient is weaker. They spent days in the hospital, in hospital beds, away from their loved ones. Like, it's really hard. And you multiply that throughout an illness and throughout the last year of an illness. And that is like a big shocking thing to the body and the mind. So if we're bringing the care that you would get anyway at a hospital and more care because you have the equipment and the medicines, and you're not worried about budgets, and you're not worrying about what to do at 2 a.m. when you have an emergency, because you can call hospice because we're there 24/7, then it makes sense that our patients tend to either live the same amount or outlive people who are continue to receive aggressive curative treatment and don't receive hospice at any point. Like, it's not rocket science. It kind of makes sense with what we intuitively know our people need. Now, that being said, part of the reason why the research has lagged behind is because hospice did not become a full specialty, like a board certified specialty, until 2006. That's like yesterday in research years, right? So by the time you get the funding to do the research and you get the data and you analyze it and you prove it and reprove it so that you have valid, concrete, good data, it takes years. So that's why now we're starting to see the data catch up with what we in the field know we see, right? All the examples that we have out there are now starting to be proven by really good science behind it. But that's why it's taken so long, because it became a discipline very recently. Okay, so just to do a big recap, and then I'll explain a little bit between palliative and hospice, because I know that's a big thing and people use it interchangeably, and it's not. I'll do a recap of hospice, I'll do palliative versus hospice, and then hopefully there's a bunch of questions out there. So hospice is not a place. It's a group of services that comes to you wherever you call home. We will follow you as you move from place to place. We cover the people associated with your care, which now you know is an interdisciplinary team of super good specialists in different areas. We take care of the medicines associated with your care, and we take care of the medical equipment associated with your care. It is all fully paid for. You will not receive different bills for different things, right? And it doesn't matter. Your ability to pay doesn't matter. Your legal status doesn't matter. Nothing matters. You will receive the care for free, period. End of story, okay? It is for people who have a life-limiting illness. Not because your great aunt is 103 means that she needs hospice. She may be kicking my butt in a marathon tomorrow, so she may not be qualifying for hospice just because she's 103, although most of our population is a little older. But what you need to have is a life-limiting illness, which is some kind of illness that if your peers don't have it, they're going to outlive you. And that illness is at a point where it's causing you so many problems and so many symptoms that interfere with your life, that you are seeking care all the time to try to just manage those symptoms. And lastly, that you are not receiving curative treatment to take care of that disease. You're not trying to abolish this disease or make it go away. And I'll give you an example. If you are a patient with a heart condition like congestive heart failure, right? You are not in a place where you're trying to get a transplant and doing the testing for that transplant every other week and so on. You are at a point where it's just about managing those symptoms, right? The shortness of breath, the edema, the anxiety, all that comes with having congestive heart failure. So seeking a new heart would be curative, right? They would take out the old heart, they would put in a new one, and semi-problem solved. Same with the lungs or the liver. Let's say you have cancer, and the cancer that you have gets you a big tumor in your spine, right? And that tumor in your spine is causing a lot of pain. Well, curative treatment would be, I'm getting radiation to that spine, to that tumor, to demolish the tumor, and that was the only tumor. And once I do that, I am cancer-free. That is curative treatment. However, if you take that same tumor in the spine that's causing pain, you take the same radiation, and the goal of that radiation is not to rid you of the cancer. It is to make that tumor smaller so that it doesn't cause pain. That, my friends, is symptom management. And that would be well in the realm of hospice. That's the difference, right? Not the medication that's being used, not the procedure that's being tried, but the goal of that medication and that procedure is what makes something either curative or symptom management. Okay. Now, lastly, what is palliative and what is hospice? Why is it that people use it interchangeably? And when do I access which one? Thank you. What happens is that all hospice is palliative in nature, right? We are under this big umbrella called palliative. We live within the division of palliative medicine because palliative is nothing more than palliation of symptoms, than management of symptoms. And that's what hospice does. So we belong under the umbrella, the full umbrella of palliative care, right? We're like the subdivision down here called hospice. Now, palliative care, where hospice and palliative diverge, is that palliative care can be accessed at the same time as you're receiving curative treatment. Let's go back to my tumor in the spine because it's very convenient. And that tumor in the spine is getting the radiation to cure it, right? To cure you of the cancer. You're going to be cancer-free after that radiation. But that radiation is causing pain in the area, redness on the skin, severe fatigue. It's causing acid reflux. It's causing you, extreme anxiety because you're not being able to work fully and everybody's dependent on your income. Well, that, my friends, is a palliative care consult. So you take that patient to a palliative care physician. In the palliative care office, they're going to do a full assessment. Instead of like a 15-minute visit, it's about an hour visit. And they're going to be looking at all of the symptoms, both physical, psychological, emotional, social, that are affecting that patient. And then they're going to try to consolidate some of the treatments and some of the medicines to deal with that redness and that pain and that lack of sleep and that anxiety and that burning sensation in the back. Okay, that is what palliative does. Now, why couldn't your regular oncologist or your PCP do that? Because they're not symptom management experts. It's like asking a cardiologist to do a complicated birth, right? They could probably swing a plain vanilla birth at the subway or in the taxi cab, right? Because there's no option, and I went to medical school, and I kind of remember what to do, the basics. And they do it, and it's fine. But anything other than a plain vanilla, I'm giving birth right now in the taxi, then you really need the specialty to deal with all of the rest of what can happen and all of the complications. So that's why your PCP and your oncologist wouldn't be able to deal fully with all of the symptoms that this particular curative treatment is receiving. Now, let's say that the curative treatment did not work. The radiation shrunk the tumor. You don't have pain, but now you have other things in other places, and it doesn't look like any of the curative treatments to get rid of that cancer are really have a good chance of working, and that's not where you want to be. Now, the palliative team gives the hospice team a call and says, hey, we've been working with this family. Can you please go ahead and consult them, because they're most likely no longer going to receive curative treatment. Okay, that is the difference between palliative medicine and hospice medicine. All right, we're like good first cousins. Okay, and then with that, that's about what I wanted to make sure we touch on. For all of you caregivers out there, you guys do an amazing job. I know how hard it is. I know it's hard to be seen. I know it's hard to be heard. And I know it's hard to advocate continually for somebody else. So know that you're seen and know that you're heard, and know that we're just a phone call away. Remember that we really, when we think about our loved ones and the disease process, a lot of people talk about hope and talk about not having hope, or denying curative treatment means that I'm giving up on my loved one, and that we are just throwing up our hands. But what I like to talk about is that hope is not really a static concept. It is not a one thing, right? You change your expectations and what you hope for based on the realities around you, so that that hope can be comforting to you, right? If I go like this and I go, oh my God, I've got a lump, I hope it's not a tumor. And then I go and they say it's a tumor, I go, oh my God, I hope it's not malignant, right? My hope is changing to adapt to my situation and support me through this. And then they go, it's a malignant tumor, and I go, I hope it's treatable. And then they say it's not curable, and then I say, I hope I'm not in pain, right? So hope, this concept of people are going to lose hope, people are giving up, I might as well continue on this curative treatment even if it has no chance of working and it makes my loved one feel worse and not experience life with any joy, because I can't, that's like losing hope or saying they're going to die tomorrow. That's not, hope is not static. Hope moves with you to support you through all these changes. And really, so does hospice. We will continue to be there supporting you, advocating for you and what you want. So don't be afraid to have a conversation with us, because that's it. That's all it is. It's just a conversation, but the choice is always yours. And as you morph and change and shift, and your hope goes with that, we will be there. So I think that's about all I wanted to touch on.
Patricia, I love hearing you speak, and you give me hope, right? You really do such a beautiful job of explaining what can be a really difficult thing for folks to think about. I've got a couple of questions for you. And folks, I really encourage you to send your questions through the chat or the Q&A, and we would love to have Patricia answer them. Patricia, one slide that you went through really quickly, it was, I think, one of the last myths. So people can still be active. That hospice isn't just for people that are stuck at home and in a bed now, right? People
Yes.
can be out and about and living the life that they have left, right?
Yes, you're absolutely right. And thank you for bringing that up. Again, with the myths, it's like, oh, you're 3 days away from death and you're comatose, catatonic. That is not true. We have traveling patients, for example. Oftentimes here in Frederick, we get them from Ocean City, and they come up to visit family and stay with family over the Christmas holiday. And they have hospice in Ocean City, so they contact us. We take over the care so that the loved one doesn't go without their medicines and their care and all of the support that they can have, so that they can enjoy the visit and then they go back. I've had patients that have traveled to San Diego to see their grandkids. So really, it is not for, it's not your grandparents' hospice anymore. It is a lot broader than it used to be. And I really encourage you to call early, because the worst that can happen is you say, that's not where I want to go right now, not yet, that's not the path that I want for myself right now. And then we have another conversation when you feel like what we have to offer matches what you want. But definitely not just for people who are in bed. We have very mobile, very active, very agile patients with us.
We share some patients, and yep, the folks who come here certainly have a lot of life left to live, and we're happy to help them do that well.
And certainly hospice is also for any age. So we have taken care of babies that have the expectation for life is not super great. For pediatric patients, we can have concurrent curative treatment as well as hospice. So with pediatric patients, it works a little bit differently, but we have pediatric patients, we have young adults, we have everybody through the age range, even if we have the bulk of our patients are a little older.
Patricia, would you speak to what would be the benefit for somebody having hospice if they were already in an assisted living or a nursing home? They already have nurses to take care of them. Why would hospice be helpful?
Mm-hmm. So that's a great question. And Rayanne, if you want to jump in here at some point, go ahead. But basically, we are an extra layer of support on various fronts. Number one, as I said, we are experts in symptom management. So we are really best versed in looking at all of these symptoms that are going on, that are happening for the patient, and really optimizing and individualizing and optimizing the treatment for that particular patient, for that particular set of conditions. We also are an extra layer of support for the nursing homes and the assisted living facilities, because we do have our home health aides that come in, and our chaplains and our music therapy. So it's really, you're layering on much more support that the patient can have. I mean, facilities do a great job. This is an extra layer of support that can be overlaid onto the job that they already do. And it's a good point of it. The communication flows really well when we're working in a facility with hospice, with the families. So our team is not taking over the care and pushing aside the facilities team. We are working all within the same support system for that family. So we all communicate really well, and it becomes a really beautiful thing to have.
And Rayanne, who is within an assisted living, wrote in, teaming with hospice will build a larger team to support the person, and also, just as importantly, or maybe even sometimes I'd say more importantly, the family.
Yeah.
And Patricia, it could be any assisted living or nursing home, or do they have to have a special hospice contract?
So in Frederick, we operate in all of the assisted living facilities and nursing homes and independent living facilities. If depending on the state that you're in or the county that you're in, if you want to work with one particular hospice that is not in a particular facility, you can always reach out to that hospice, and the hospice can reach out to that facility to have a one-time contract for that particular person. This sometimes becomes important for people living in places where they have like 10 different hospices, or 12 different hospices to choose from, but the family feels most comfortable with one particular one. But in Frederick Health Hospice, we can work with all the facilities.
Patricia, could you speak a little bit about dementia? Someone's asked us a facility-specific question, but I think it could be extrapolated to home as well. But when is the right time to call about a person with dementia and being appropriate for hospice? In this case, the person's still talking, walking with assistance, and eating well. How does hospice decide when a person with dementia is eligible or appropriate for the service?
That's a really good question as well. And I'm glad you asked it, because it has actually changed throughout the years. It used to be, when I first started in hospice in 2014, you had a category of people that didn't really fall into any particular diagnosis. They just were under failure to thrive. Like you see that they're not eating as well, that they're losing some weight, but it could be your 103 that stopped running marathons and now is kind of just having a harder time, but there's no particular disease. Unfortunately, Medicare took that away from us, that ability to serve that particular patient, and they've kind of clamped down on dementia as a category of who we serve. So if it's straight up dementia, if there is nothing else going on, and there's no weight loss, and there's just nothing else going on, the person is doing great but losing their car keys too many times. Oh wait, that's me. Never mind. They're losing their shoes or not remembering where they're going, different than it used to be for them. They're still probably not going to qualify for hospice, because the longevity of that patient is totally unknown. Like it could be, 5 years, or it could be 3 years, or it could be 4 days. So at that point, it would be difficult to qualify them just for dementia. However, if you're interested, I encourage you to give a call and to say, hey, I don't think they qualify just yet, but what should I look for specifically in this context to know that they are, that they're getting close to being eligible. And we will also look at the medical record, because sometimes we find other reasons to be able to admit them that is not dementia. It's something different. It's something else. Oftentimes dementia co-occurs with other diseases, and we could look at that and say, okay, we can qualify them for hospice under this particular area. So if you have the walking, talking, eating well person with dementia, just call the hospice and say, I don't think we're there yet, but I wanted you to be aware of our situation, and please check with us, every 3 months, and I'll update you on what's going on with the patient to see when we can qualify them.
Patricia, I think that takes me to something you said earlier. For anybody, whether dementia is the diagnosis or cancer or heart disease or anything, calling. You're not committing yourself to anything if you make a call to hospice. The people that answer the phone are lovely and kind, and you can have a conversation with somebody about your situation and determine if now might be the right time or when the right time might be, right?
Yes, absolutely. I absolutely agree with that. And especially for people who are dealing with a chronic condition, or certainly people who are dealing with, for example, cancer that has been really kind of chronic in nature, where you're talking about years and years of just managing and dealing and extinguishing and comes back. It could be really difficult to think about doing something else or having a different pace of routine. Oftentimes I say that, like, getting off that hamster wheel of going seeking treatment, and what do we do now, and what do we do now, and let's try this, and let's go there, and let's go back to the hospital. Like, it's an intensity that we feel as caregivers that is always churning. And although we all want to get off of it, when we do, we feel like we're dropping the ball somewhere. Like, it feels so out of character for us not to be coordinating and managing and putting out fires and calling the insurance and doing this and being active, which in a way can be comforting when we have somebody that is sick, to feel active, to feel like you're doing something. So sometimes it's really hard, especially for us that work with people that are sick for a long time, to make those calls and to try to look at things in a different way, because we're so used to it, and there's a comfort in having those routines where we feel we're doing the best for our loved one. But that typically ends up in burnt out caregivers, even if we don't know it. It puts us at greater risk for chronic conditions ourselves and not doing as well. And if we're out of commission, nobody can help our loved one. So it's important for our self-care to be able to think about reaching out to other community partners like hospice and saying, hey, what do you have to offer? And then if you decide that it's a possible good match and the patient qualifies and you try it, to give it a couple of days so that the anxiety of not doing something all the time for your loved one kind of goes away, and you can go back to being wife or daughter or son or mother or aunt or whoever you are to the patient other than their caregiver. And I acknowledge that that's really hard in the beginning to do, but it's something that saves the caregiver, saves the patient that knows what their caregiver is going through. And it could be a really lovely gift for both of them.
Thank you, Patricia. That really sums it up really well. Folks, we've got just another minute or two. So I urge you, if you've got a burning question, please ask it. If you don't, again, I encourage you, give us the phone number again, Patricia, for Frederick Health Hospice.
Yep, it's 240-566, 566-3030.
Perfect. It has been a pleasure to have you. I thank you. Folks, I will send you out the PowerPoint that Patricia used today. It also has the contact information. We also recorded this presentation, so we will have this on the ESPC website very soon. We've also shared the phone number in the chat box. So I thank you all for being here. This was wonderful information. I encourage you to join us next month. I believe it is April 9th is our next, April 13th is our next webinar. We will have a team of caregivers who have been through the journey and have a lot of going to share their lessons learned, and hopefully that might give you all some insight and ideas as you navigate your own journey. So I welcome you. I do want to let you know we are moving to a new registration platform. I will send out emails from me as I have been doing to get you all started, but the registration will be through a new link. The emails will come from ESPC. And again, we will kind of do them in tandem this month to get everybody on board. Everything else will be the same Zoom link, the same webinar features, but we're just moving to a new platform. With that, I wish you all a wonderful afternoon. I do want to say, Patricia, some great notes of thanks in the chat box. Wonderful presentation. And every time I hear you, I think the same thing. You are very passionate about what you do and a gift to this community. So thank you. Everybody be well. Thank you. Don't hesitate to contact Hospice if you have more questions. And we look forward to seeing you soon. Take care, everybody.
Thank you.
And again, thank you, Amber Hill Physical Therapy, for supporting us this afternoon. We appreciate it.